everyone. I'm Dan Rabin, and thank you for joining the Branford Forum today. We have a few introductory remarks, and then we'll get underway. I'd like first off to thank Jenna Anthony at the Blackstone Library, who has set up the Zoom call and has been supportive and faithful over the years. So thank you, Jenna. We have a great program set up for the spring. On February 20th, Professor Paul Friedman will talk about the history of American cuisine and how it got this way. He's a professor of history at Yale, and he has two interests. One is medieval history, and the other one is American cuisine. So that will surely be an interest. I actually heard him speak on NPR, and he's a great speaker. That's our next program. On March 20th, Bernie Pelletier will speak on addressing climate change through local initiatives. And Bernie was the sort of the godfather of our successful Heat Smart program that we ran last year. So that's going to be a very interesting talk. April 24th, Kurt Johnson from the Save the Sound, will talk about healthy sound, resilient communities, opportunities and challenges. And then on May 22nd, Bob Barnett, who's an architect, will be talking about deconstructing stone buildings. And he's also, both Kurt and Bob Barnett are Branford residents. They'll be talking about local issues. So I think there'll be a lot of questions today. You can either write your questions into the chat, or we'll have an active Q&A at the end. You know, we can raise the hands or recognize individuals if they'd like to speak their questions. We will be recording the session today. So if you don't want to be seen, this might be a good time to shut your video off. So I think we'll start the recording. So welcome everyone. My name is Dan Rabin, and this is the Branford Forum. It's a special pleasure today to have Professor Gerard Sanacora, who holds both MD and PhD degrees. He is a professor of psychiatry at Yale and director of the Depression Research Program. And he's going to speak to us today about emerging therapies for depression and anxiety. Professor Sanacora, thank you so much for joining us, and we'll look forward to your presentation.
Thank you very much, Dan. It really is a pleasure to be here. I'm just a town away in Guilford right now, so it's really nice to get this chance to talk. Dan and I talked a little bit before time about what's the best way and what would make this most interesting. And I have to say, hearing some of those other titles, they sound more interesting to me than hopefully not, but maybe a little bit more than what I have for you. But I really do want to try to keep this interesting. Most of the lectures I give are very much geared toward scientists or medical clinicians. So I'm going to try to turn this around a little bit. Much of the data I'll be showing you is real scientific data and clinical data, but I'm going to try to highlight the points that I think is most relevant to this discussion, is really how our thinking about things like depression and anxiety disorders have evolved over the past 20 years, and how that's now leading us to new forms of treatment and hopefully ultimately to preventative measures that we can take. So 1 second, I just want to make sure I have to share my screen here for a second. Let me get that going. Okay. So don't let the title sound too intimidating or anything about emerging therapies for mood. Some of these slides may seem like they're really packed with data, but really the main point is to just get the bigger picture here. So the screen is sharing now. Are you seeing the shared screen? Good. Okay. I do a fair amount of work. In fact, some would say a lot of work with the pharmaceutical industry and other companies. So these are my disclosures I always like to share. I work with many different companies, and I have some direct relationship with some of the local companies like Biohaven Pharmaceuticals. But just to put that on record. And as I said, today, what I'm really hoping to get across is one, to hopefully convince everybody that despite the fact that we do have good treatments for mood and anxiety, there's a lot of room for improvement, and we still need better ways of treating these disorders. And then really the crux of this whole discussion is to talk about how our thinking about depression and anxiety has evolved over time. And then I just want to use a case example of one of the newest drugs, in fact, the most recent drug to receive FDA approval for depression, and how that came out of this model of translational neuroscience, and then to talk about what it means for the future. So let me just get started with, do we really need novel treatments for depression and anxiety? I'm going to back up one quick second and just to talk a little bit about what depression and anxiety is, since I'm not expecting that everybody in the audience has a medical degree or is a psychologist in some way. And these are tricky words because depression and anxiety are words that very much cross over into our lay lingo, our discussion. We use these words a lot. Somebody's feeling depressed, somebody feels anxious. They're very normal emotions and normal emotional states or affective states. When we talk about it from a clinical side, we're usually using the words like major depressive disorder or anxiety disorders such as panic disorder or generalized anxiety disorder. And I think the main point to remember is these are disorders that cause significant impairment. It just isn't feeling down or depressed or sad. In fact, many people with depression may not even feel sadness in the term that we think of sadness. They have other symptoms that really meet that. And it really runs a range of physical symptoms, typically with sleep and appetite and the speed of being able to move and think, to cognitive, which is feelings of sadness or not being able to process thoughts at the rate that you would normally be able to. And then at the far extremes is to the point of not wanting to live anymore and frequently being associated with suicidal thoughts and in the worst case, actually suicidal behaviors. And that's for depression. Anxiety is that crippling sense. I think we all felt anxiety at some point in our life, you feel it. But this is for the people that suffer from these disorders, either a generalizing anxiety disorder or a panic disorder, is this crippling feelings significantly impair their ability to function. If you can imagine having that terrible feeling of anxiety that we've all felt at some point, just popping up unpredictably, or even worse, just being persistent and chronic throughout the day. So that's really, that fine line. The other between what is healthy and what is the disorder. The other very tricky thing that we work with in the field is these are what we call diagnoses of exclusion, and a fancy word in medicine, but it means that we don't have a test for it. So it isn't like we can do a test for, if you have a strep throat, we can actually do a test and see if you have a strep infection and you'd be positive. There is no test for depression. There's no test for anxiety disorders. And there are a lot of different things that can actually cause depression and anxiety. So what we have to do is make sure that we rule out all the other possibilities. So for example, having impaired thyroid function, having a thyroid that isn't functioning correctly, hypothyroidism, can lead to many of the same symptoms as depression. But we can do a test for that. We can test your thyroid function to see if it's working okay. And if it isn't, then you'd be diagnosed with a thyroid disorder. But depression, we don't have a test. So what we have to do is rule out all the other possibilities. And when we can't give a diagnosis, we're left with depression or anxiety. And that makes it very complicated because there probably isn't a single illness. It's probably still many different things that can get you to the point of being depressed. So when we say somebody has depression, it means they have this constellation of symptoms, and we can't find another reason for it. So it makes it tricky, and there's no reason to think that there's going to be one treatment for that. So it'd be maybe more similar to saying somebody has a cough or a fever. There are many different reasons you could have a cough and a fever. Fortunately, there are some medicines like Tylenol, or acetaminophen, that will take care of fever in most cases, regardless what the cause is, which is good. It may not cure the ailment, what you have, but it could at least reduce the symptoms. And that's in a way, when we're dealing with depression, anxiety, we're two things. One is actually changing the course of the illness, reversing the illness. The other is just targeting the symptoms and reducing the symptoms. Okay, so that's sort of the background to the whole story. And it's a lot to get right up front. But I think most of you are at least familiar when we're talking about depression or anxiety, what we're talking about at the most general sense. What I think people may not realize is the impact that especially depression has on society. So I know it's shocking to many people, but according to the World Health Organization, depression is either the first or second leading cause of disability throughout the world presently. Now that, I think, shocks many people, depending on where you are. But in terms of disability adjusted life years, in other words, how much disability occurs over the lifespan of somebody, depression is actually one of the major causes of disability throughout the world. The other thing that people are surprised to hear, and it really is a little frightening to people, is that suicide, which is frequently associated with depression and anxiety, in the US is actually currently, I believe, the 10th leading cause of death. But below the age of 34 is actually the second leading cause of death, especially between about 13 or so and about 34, which is shocking. Right now, most recent years, somewhere around 45 to 47,000 people per year die of suicide, and that's probably underreported. And one of the more frightening thoughts is the rates are increasing over the past 2 decades, at least in the US. So far we have one of the most common and most debilitating illnesses, and one that unfortunately the trend is going in the wrong direction. Things aren't getting so much better, if anything, moving in the wrong way. And the last thing, don't even try to read these figures and numbers, they're way too small. But this is the results of a large study that was completed about 10 to 15 years ago, called the STAR-D study, which is a large study funded by the National Institute of Health. And it was really aimed at looking at, in normal real world practice, how treatments for depression, how effective they are, and how best to sequence them, which one to give first, second, third, fourth. And the data from that I'll talk about was very enlightening. It was humbling in a way, enlightening. The good news is the majority of people did quite well with treatment. So about 60% of people, 65% of people would actually get to the point of having a remission from a depressive episode with treatment, going through 4 different rounds of treatment. The more concerning parts is only about 1/3 of people, and I actually go to the next slide, about 1/3 of people got better on the first medicine they were taking. When I mean better, in this case, it means pretty much back to normal, as close back to normal as you could measure. About 1/3 with the first medicine they tried. If that didn't work, if they went to a second medicine, again, about 1/3 of the people would respond to that second medicine. The problem really comes is if people didn't respond to either the first or second treatment, and these are either many of the standard oral antidepressant medications or even cognitive behavioral therapy, which was a talk therapy, either used alone or in combination for these first 2 rounds. The problem was if people didn't respond to these first two treatments, the chances of responding to the subsequent treatments dropped dramatically. So here we can get about 1/3 of people better with the first treatment. Of the ones that didn't respond, again, about 1/3 would respond to that second treatment. But when we went to that third level, if people didn't respond to the first two treatments, the chance of responding to that third treatment dropped to less than 15%. And the same with the fourth round of treatment. So it really is a call to us that our standard medications, again, this was as of 15 years ago, 15, 16 years ago, when most of this work was done, were good. They were good for many people, but for a significant proportion of the population, probably somewhere around a quarter of the people that struggled with depression, the existing medications at that time really did not bring adequate or satisfactory benefit. And just to sort of highlight the need for treatments, as I mentioned, the trends for suicide seem to be moving in the wrong direction. But what's very frightening is the rates of depression and anxiety over the past 2 years are skyrocketing, especially in younger age groups. This is probably in large part to the pandemic and all the social isolation and limited social interactions that are occurring, but these rates are going up at an alarming rate. And especially in the adolescent and pediatric populations, this has created a real crisis, leading actually to the Surgeon General issuing an advisory of a crisis brewing here, where there's much more need for mental health care than can actually be provided, especially in this younger age group. So I hope I've done a fair job just convincing people that there's a real need. We do really well, we meaning the field in general, in treating a large percentage of patients with standard of care treatment, meaning oral antidepressants or straightforward psychotherapy. But unfortunately, there's still a significant proportion of people that really aren't obtaining the level of benefit that we would hope they could get from these treatments. And I want to go back a little bit and just talk now about how things have evolved. So everything I showed you in those slides were, in terms of how people were doing, only went up to about 2005, 2010, somewhere in there, that those data were collected for in terms of the treatment. And almost all the medications that were available at the time, and even to this day, the large majority of all the medications that were available came out of what was called the monoaminergic theory of depression. And it's probably what many of you have heard of: serotonin, norepinephrine, and maybe a little bit of dopamine. That was, even when I was in medical school, that was the textbooks, that was everything. This idea that depression was caused by low levels of norepinephrine or serotonin, or then it evolved into thinking, well, maybe it's not just low levels, but maybe it's the way these systems function in the brain that was causing the depression. And that really goes back to work that was done in the early 1960s, mid 60s. And this is actually a paper from 1965, sort of reviewing some of it coming out of the NIH. And that basic hypothesis, or that basic theory of what was going on in depression, led to all the drug development through the turn of the millennia. So all of these drugs were based on very similar models. So I use the comparison many people are familiar with: antihypertensives, blood pressure medicine. And there's many different classes of blood pressure medicine. That some of them target the way your kidneys work. Some of them are just what's called beta blockers that just block your blood pressure that way. Other ways just make you urinate more and drop your blood pressure that way. There's a lot of different ways of targeting it. For depression, it was like we had one type of treatment. And if that didn't work, we just tried another one of that same type. They were all pretty much within the same class with minor differences. So it was not so surprising that if the first or the second one didn't work, trying the third, fourth, or fifth didn't seem to add much to that. There were really sort of different flavors of the same ice cream. Really, it wasn't really meaningfully different in the way they were working in the brain. So to look at where success has gone, I've shown you that we haven't really improved our treatment of depression over the past 4 or 5 decades since the development of these SSRI medications, or even before that, the development of the tricyclics. I always like to go back and look at a model where there's been great success in reducing, and the easiest way to measure this is death rate and age-adjusted death rate. So this is coronary artery disease or heart disease, age-adjusted death rates. So this goes back to the 1950s, which is not, right about where we started talking about with the antidepressants. And in fact, the rates of death due to heart disease were increasing gradually from the 1950s to the mid 1960s. And you can see the projected line would continue to increase. In reality, what happened is there's this precipitous drop off in death, age-adjusted death due to heart disease over these years, which is really pretty phenomenal. Estimated that millions of lives have been saved, or at least extended for significant periods of time, due to the advances that occurred. So it's really nice to look at a model, and you start to think about, well, what really happened in the 1960s, mid 1960s, 1970s that led to this precipitous drop off in age-adjusted death rates, or this improvement in the way we manage cardiac disease. And there were several things that occurred at this time. Maybe the biggest was we started to actually understand what we call the pathophysiology, or the pathogenesis. 2 big words, but all it means is what was actually causing heart disease and what in the body was going on. What was the physiology behind it? We started to understand things like cholesterol building up atherosclerosis, and that higher cholesterol levels could actually build up the atherosclerosis quicker. We started to understand that long-term hypertension, high blood pressure over many years, could actually stiffen the vasculature, making it more difficult for that blood to get through. We started to understand that changes in metabolic activity, untreated diabetes, and other factors significantly worsened the coronary artery disease. And probably most importantly, we started to realize the major risk factor of smoking, and how bad tobacco smoke was for your coronary arteries. And able to, one, start to really develop more effective treatments for your blood pressure, to develop things that were able to manage your cholesterol, and then get your diabetes under better control. Although we haven't done such a great job, we know how to treat it a lot better, but we have higher rates of it now. But maybe even the most important is to get people to stop smoking. That preventive measure, where we understood the major risk factor and we were able to implement changes, we had a huge impact over time. And granted, we've gotten better at doing coronary artery bypass surgery, putting stents in, doing balloon angioplasty, a lot of other advances too. But if you really look at the raw numbers, it was these early treatments and prevention strategies that did so much. So now we take this back to depression. So what do we learn from that? So this is just a recent paper that we wrote for Nature Reviews Neuroscience. It's this idea that, to me, when I think of it, what smoking is to coronary artery disease, stress or perceived stress is to many neuropsychiatric disorders. It's this uncontrolled level of stress. And it's much more complicated than just saying, well, stress is bad for you, because that's not true. In fact, we know stress can actually improve brain function. In animal models, that's very clear, but even in humans, there's good evidence that some levels of stress are actually beneficial in terms of brain function. But it's this combination of the intensity of the stress, the duration of the stress, and the perceived control of the stress that play major factors. So we know in rodent models, putting them through a little bit of stress and then having them do memory tasks, they actually do better than if they had no stress. But if we give them too much stress, Or if we put them in a stressful situation that they can't escape from and feel they don't have control over, then it worsens their function. And we can actually look at those changes as they occur in the cells in the brain. And we can actually see that chronic periods of stress or high intensity levels of stress can actually have toxic effects on the brain, which is opposite of controlled shorter term levels of stress in these animals. So we start to think about how this is related to depression or anxiety. And there's a lot of work going on at this point in the rodent models, showing how the actual neurobiology down to the receptor levels and the changes in gene expression that occur with long-term stress, and to the level of how it changes the circuitry in the brain. Each general region of the brain exists at different levels from the individual cells, but then the cells work in circuits, and then these circuits work in larger networks. And we're starting to really understand how these networks interact for adaptive changes in the brain for humans to function. And we're starting to learn how stress can impact all of these changes from the cellular to the network, and how these effects of stress in the rodents in many ways actually reducing. So right here, I don't know if you can see that, we can show examples in rodent models where chronic periods of stress can actually reduce, these are called the dendritic branches. So these are how neurons connect to each other and send messages back and forth. With chronic levels of stress, you actually get a retraction of these. It's almost like a pruning of a tree, taking these branches out, reducing the connections. And this over here is looking at the actual individual synapses, when you start to see these spines, how stress reduces those. And again, this is chronic levels of high stress. In humans, we're starting to develop evidence very much the same thing. We can show that people with depression, which is highly related to levels of stress, actually reduce brain regions, reduce volume of specific brain regions that are sensitive to stress. In this case, a brain region here called the hippocampus, it actually becomes reduced in patients with depression. Now, unfortunately, it's not that we can do a test. We can't do an MRI in somebody and say, oh, your hippocampus is reduced, that means you have depression, because everybody has a slightly different hippocampus. It isn't like a normal volume. We can say this is what you should have. But if we look at 200 people with depression and 200 people without depression, the 200 people with depression are going to have smaller hippocampus in general. So it's important to realize that it's not a diagnostic test yet. But we do have good evidence that the people struggling with depression overall seem to have reduced volumes of that brain region. And it does seem to be related to how long they've been ill. So if you look at that, the longer periods of depression being untreated, the smaller that brain region is. And it's just an example of how stress is having these toxic effects on the brain. I'm going to skip through that slide. So the main point here is we're starting to understand some of the risk factors of depression, and we know stress is one of the main ones, and we know we can start to target that in many different ways. And one of the examples I want to do is talk about a pharmacologic development and how that actually was developed. So I talked before about stress reducing some of these brain regions in rodents. Well, in humans, as I mentioned, we can show that the hippocampus is reduced with people with depression. There's also another brain region. It's not important to talk about. It's the anterior cingulate cortex, another part of the brain that seems to be dramatically reduced when patients are severely depressed. And more recent, more recent meaning 20 years ago, this is around the turn of the millennia, evidence showing that some cells in the brain, not the neurons so much, the neurons look like they may reduce in their connections, but not that they're actually less neurons. The same number of neurons seem to be there. It's just they're not spreading out their dendritic branches as much. So it's kind of like the tree isn't really growing the branches nearly as much as it would under other conditions. But the trees, it's not less trees. But these other cells called glial cells, which are also in the brain, do seem to be reduced in number and in density. So we're starting to understand a little bit more. And again, there's on the bottom here, we see this is exactly what we see in depression, but it's also what we see in rodent models of stress. And one of the other advances that came around the turn of the millennia, so much of this work was done in the late 1990s, was work by people like Bob Sapolsky. If I don't know if some of you may have heard, he had some best-selling books, Why Zebras Don't Get Ulcers, and other work like that. But really, one of the leaders in trying to understand the effects of stress on the brain, on the biology of stress. Bruce McEwen, another major leader in the field, started to understand that's how stress was having this toxic effect in the brain. And other work by colleagues at Yale showing that when you acutely stress an animal, you get these large releases of another neurotransmitter called glutamate that some of you may or may not have heard of. Many of you probably heard of serotonin, norepinephrine, dopamine, but may not have heard of things like glutamate and GABA. And interesting, glutamate and GABA are the two main neurotransmitters in the brain. They're the main chemicals that's used for cells to communicate in the brain. Serotonin, norepinephrine, dopamine, you may have heard of acetylcholine. Those all together account for maybe 5% of all the chemicals in the brain. GABA and glutamate account for the other 95. So they're really the main chemicals in the brain doing most of the communication between the cells. More and more evidence started to develop that the glutamatergic system, which has a lot to do with regulating neuroplasticity, which is another fancy word, but it controls how these neurons are connecting with each other and talking to each other. More and more, we started to understand how stress alters that system and then has these effects downstream on the brain and how it communicates. And a lot of this work all started to come up around the turn of the millennia. And also just the way the history goes is it's really interesting to see there were other animal models that were showing that when animals are stressed, you can affect things that were related to memory. So some of you may have heard of another term called long-term potentiation, big fancy scientific term, but it really is just the way that the brain learns. It's the way that it learns new things through having coincident effects. So it learns if A plus B equals C in a very simplistic term, but starting to understand the neurochemistry behind that. And groups, again, at the NIH started to realize that this was disrupted in animals that were stressed. And a lot of this work was mediated through the glutamatergic system. So interesting, with all that work going on, some of my colleagues back at Yale, actually at the West Haven VA, started to have the idea that, well, if it seems like these brain regions, meaning the brain regions in the cortex, seem to be so heavily involved in depression and stress. And if this glutamatergic neurotransmitter system seemed to be playing such an integral role in it, would it be possible to use a drug that targets this system? And would that have an effect on depression? Different than the monoaminergic drugs, which were the serotonergic drugs like SSRIs, or drugs like Prozac and Zoloft and all of those that work mainly in the midbrain, and then have its effect up on these other brain regions. The idea was, well, what if we tried to use a drug that was largely targeting the glutamate system and largely targeting the brain regions that showed the greatest evidence of abnormalities? And they tried a very old drug, a drug called ketamine, that some of you may have heard of. Ketamine was developed in the 1960s as an anesthetic. It is still commonly used in pediatric anesthesia. It's a drug that specifically targets the glutamate system and a specific receptor in the glutamate system called the NMDA receptor. But my colleagues at the VA at the time had the simple idea of, well, let's try. What if we give this drug to people with severe depression? So 1 week they gave the actual drug, and they saw how well people did. And this is a rating scale called the Hamilton Depression Rating Scale, which measures the severity of somebody's depression. And going lower is better, meaning you have fewer symptoms. So 1 week they gave just a regular IV injection of saline, just, the term placebo, just regular water. And so no effect in their mood at all. But the time they gave ketamine, they saw people getting better within 2 hours, and by 3 hours showing a big benefit. And interestingly, it lasted for 3, 4, 5 days. People were saying their depression was almost gone, which was really different. That's unlike anything that had been seen before. And especially strange since the drug only lasts for about 2 hours and it's gone from your system. So we're seeing people get this drug, the drug is gone, but yet they continue to feel better for days after it. And they didn't get that when they just got an IV infusion otherwise. And you can see my colleagues, John Crystal was one of the main people running that study. I mean, it was really, to I think everybody's amazement that people got better that quickly. The idea was there that this novel system may be beneficial, but nobody expected to see people getting better within hours and staying better for days, despite the fact that the drug wasn't there. What we actually think is happening is that this drug is initiating a whole process of events that leads to changes in that, what I call neuroplasticity, where the brain cells start to talk to each other differently now. It increases the ability to have adaptive changes in the brain. Since then, those studies with ketamine have been replicated many times. This is one from the NIH, where you could see that with 1 day after the infusion, 71% of people were reporting being at least 50% better, with about 1/3 saying they were totally better. So if you remember with the standard antidepressants, that's what we would typically see after 8 weeks of treatment. So really remarkable changes that people were reporting at the time. And since then, this has been replicated many, many times that we can see that effect. And more recently, now we're moving into the past 5 years, the Johnson & Johnson or Janssen Pharmaceuticals have actually developed a version of this ketamine, which has been around for a long, long time, which is S-ketamine, which is really just half. I probably don't have too many organic chemists in the audience, but most drugs or most things exist in 2 versions, mirror images of each other. And that's what ketamine is, has both like a left-handed version and a right-handed version. S-ketamine is just taking the right-handed version and leaving the left-handed. So it's almost the exact, in fact, it is just half of what's present in the normal ketamine. And they were able to do this and then do large studies. Now these are studies with thousands of people all total each one of these studies has between 200 to up to 600 people in some of these, up to 800 people in some of these studies that were done to get FDA approval. But you can see, I don't want to go through each one, that the drug did well in separating from the other standard antidepressants. So in these trials, everybody got a new antidepressant, and these are all people that were treatment resistant, meaning they didn't respond to at least 2 standard oral antidepressants. So they were all in that group that I kept telling you about, that don't respond to the classic antidepressants. Then they were started on a new antidepressant, and then on top of that, either got this new drug, ketamine or S-ketamine called here, or they got IV placebo. And you can see 2 things that I've learned from this study that's really important. One, the drug really does seem to work very well, separating, and you can look at remission rates. This is meaning people saying they are feeling completely better, or response rates. And you can see remission rates up as high as 52% of people now saying, and these are the people that didn't respond to classic. So we'd expect only about 15% of them to report feeling significantly better. Now you can get up to 40 or 50% of those people saying they feel completely better. The other amazing thing that I've learned from this, though, is even the people that got the placebo, they got the standard of care, meaning they got a new regular oral antidepressant, but got all these other IV treatments, did much, much better too. They were having remission rates of 30%, which is twice as high of what you would expect based on the other studies, which to me means that giving very close care. These people were coming in and they weren't getting IV, they were getting nasal spray twice a week for a month, were getting so much better. And I think that really reflects the close clinical care and follow-up that they're getting. So I learned two lessons from it. One, close clinical care and follow-up can be very important and really beneficial. And two is the drug actually does seem to work even on top of that. And then you can see that people that continue to take the drug either once or twice a week going for a year can actually maintain that response over time, which is really important. I'm going to move through a little bit and just show the other studies that were done. And these are all FDA, these are all studies that were shown to the FDA for FDA approval, with two other studies that we did at Yale in collaboration with many other sites that was sponsored by the pharmaceutical company, Janssen, where these were people that presented to the hospital either after a suicide attempt or presented to the hospital with suicidal thinking so severe that they had to come into the hospital. And then only at that time, they were provided the standard of care treatment that we would normally give, whatever medication that would be, or talk therapy, whatever. And then on top of that, were randomized to either receive the experimental drug esketamine or saline placebo. And now you can see, looking at these rates of remission between these studies, after a month, over 50% of these people reporting to be having minimal symptoms at all of their depression, which is really pretty striking. But again, even if they just got the saline, you're getting about 40%, which is pretty good. But these are people that keep coming in and getting they're regular oral antidepressant, but keep coming in for regular care with their psychiatrist, up to twice a week. So major lessons, just to wrap this up, because I wanted to give this as an example. Now the problem really is, and it's very timely, as it looks like the divisional games will be starting in about a half hour or so for football. But a major lesson that came out of this is just getting into the red zone, for those of you that are football fans, meaning, getting close to the goal line, doesn't necessarily mean that you're going to score or really have the full benefit that you want to have. This whole idea of translational science is that we have a good understanding of the basic biology. And then once we understand the basic biology, we can translate this into clinical medicines. And then these later phases is that we can actually bring these clinical medicines to patients. And then most importantly, that we can provide it and have health equity, that it's available to many people or to everybody ultimately. That's not so easy to do. These are incredibly expensive. Those studies that I talked about, my estimate is that probably running about $1 billion price tag. That's with a B, $1 billion to do those studies to show that that drug was effective. So incredibly expensive to get it to this point. And now once you get it to this point, making it available to patients, it's an expensive drug to deliver to people. It costs, upwards of $10,000 to $15,000 over a period of a month to treat people with this drug. It costs a lot of time from the healthcare. People have to come in to get treated. And we can talk more about all that if I leave some time. It's not easy. It's not something you can do at home. So you start to talk about getting it to that final stage of bringing it to patients. And that's some of the lessons we're still trying to learn as we improve our understanding of depression and anxiety. We're getting much better at treating it, but it comes at a very high sticker price that it limits the ability to actually provide it to many people. And that's really where I just wanted to leave off. I think we're making tremendous strides and advances, in our ability to treat. I just want to get to the end. One more thing, but our real struggle now is how to bring it to people. One of the new things that some of you may have heard of, which is similar to this, is the idea of using psychedelic drugs. And again, ketamine is a drug that does have effects on cognition and perception, which is pretty unique. We are actually doing a study now with psilocybin, which is magic mushrooms, some people may know it as, which early data coming from Johns Hopkins and NYU and some of my colleagues over in the UK suggest that it may be very beneficial. But one of these other treatments that if it does help is going to come at a very high sticker price. The last thing to talk about is how we're evolving our care of mood and anxiety disorders. And this is one that may have a much bigger impact on society than anything, isn't the development of a new drug or a new treatment or a new anything. It's really trying to figure out how to make the treatments accessible to patients. The bottom line is the demand is much greater than the supply for mental health care. It's almost impossible, and I don't know if people have experienced that at all, but trying to get care for yourself or for healthcare, for a family member or anything, it's almost impossible to find a provider at this time. It's many psychiatrists don't accept insurance anymore. Many psychologists don't accept insurance. It's cash only because the demand is so great. They just can't keep up with it. So part of what is going on is a whole new movement to try to figure out how to integrate mental health care into standard healthcare with your primary care provider in a much more efficient and effective manner. And I think this is some of the stuff we're going to see over the next year. For me as a scientist, it's not so exciting with the new neurobiology or new anything else, but when you want to talk about helping the largest number of people, I think this is where we're going to see the most excitement. So I'm going to wrap up with that because I really wanted to leave time for questions. I think for people, it should be a time of great excitement and really optimism that we're starting to understand a lot more about how the brain works and how we can treat people with depression a lot more. We're really starting a whole revolution about thinking of novel ways of treating people, but we're also starting to understand as we develop these new treatments, there are a whole new set of hurdles that we have to address to actually get there. I'll leave this slide up a little bit. If anybody has any questions that they want to reach us, we are running several studies right now with depression, anxiety, at the Yale Depression Research Program, and we have a large clinical program with Yale New Haven Hospital using these and many other forms of treatment too. But I'll leave it like that and hopefully have time for questions.
Great. Thank you so much. Maybe we have a couple of questions here. Maybe I'll start it off by asking, you use well, I'll call it the S word, stress, many times. Is stress the underlying cause of a significant amount of depression and anxiety? And if it is, have stress reduction protocols been tried beyond talk therapy or beyond pharmacotherapy?
Yeah, great question, Dan. So it's very hard to say, is it a major cause? I think it is fair to say, and I think most of us in the field say it's a major contributing factor. So again, I would use the analogy going back to other fields of medicine, where smoking is a major contributing factor to heart disease, to lung disease. It may not be the direct cause independently, but it is clearly highly associated with it and seems to be a major contributing factor. So I think that is fairly well agreed upon. stress itself is a very complicated thing. As we tried to say, what's stressful for one person, I actually enjoy talking to large groups of people, not into a black screen. I much more prefer to be in person. But for a lot of people, that would be a nightmare. And I hate to drive, so I hate going on long drives, but for other people, that's pleasurable. So I think, it's hard to measure stress in that way. But I think this idea of what we call perceived stress is so important. And if anybody wants to read some interesting books, like I mentioned Robert Sapolsky before, Why Zebras Don't Get Ulcers is a book that he had, best-selling book, probably 10, maybe even 15 years ago. But it talks about how the evolution of our stress response system, the biological evolution is a lot slower than our social evolution. So the way our system works, the way our stress responsive system, our immune system, our stress axis, our hypothalamic, pituitary, adrenal axis, the things that manage stress in our body, they were developed in a time period more so where if you were being chased by a smilodon, you either made it into the cave and were safe or were eaten. And when that, the stress was there and then it ended. That's not common day. Now it's, your boss is writing you, you have your PhD dissertation that's 4 years away. You have these stresses that don't come and go. They're much more chronic and much more perceived. It's not that you're going to die or be eaten by the saber-toothed tiger the next day. It's just this perceived stress that goes on and on and on. And the argument has been made that our bodies haven't had time to evolve to look at that stress as different than the stress of being chased by the tiger. So, so that is the idea. And there is good evidence that stress reduction is very helpful. So basically cognitive behavioral therapy isn't a way of decreasing this perceived stress. But other things that we know, exercise, for example, seems to counteract many of these effects of stress. Meditation, mindfulness. So these things all seem to be beneficial, and if used, can actually really help people.
Thank you. Carol asked, the symptoms of depression and anxiety are different. Why are the two so often lumped together?
Yeah. So you're right. The symptoms are different, but what we call the co-occurrence is so high. So the large majority of people that are experiencing depression also are experiencing high levels of anxiety, and many people that have anxiety also suffer from depression. So if we look at like a diagram, they'd be overlapping to a large extent in the middle. Now, obviously, there are people that have pure anxiety disorders and people that have pure depression, but there's so much overlap. The interesting thing is our field, sort of the scientific end, the neuroscience group within psychiatry, are moving further and further away from these terms, even like depression, anxiety. For years, we've had these diagnoses. I do this a lot with my hand. We've had these diagnoses and we've tried to map the neurobiology onto these diagnoses to try to make the genetics, the neurobiology map onto that. And we've not really been very successful at that. There's a new approach, and it's captured a lot by the National Institute of Health, the National Institute of Mental Health specifically, approach of what's called the research domain criteria, which is to totally reconceptualize how we think of these. And we know a lot about the brain. We know these networks, these circuits, these cells, and we know how they work to control things like appetite and sleep and anxiety and fear and reward. So what we try to do is we start to think of the neurobiology and how these different systems are involved, and then to change our diagnoses to map onto that. It's a big difference. It's not how psychiatrists are currently trained. It's not how the DSM, which is the diagnostic manual that people use, not how your insurance covers things, but it is the way the science is moving now. It's not to try to understand the neurobiology of depression. As I said, there probably is no one single thing called depression. Depression is you have these symptoms and we don't know why. Now what we're trying to understand is much more the neurobiology of it and then change the diagnosis. I hope that's helpful.
Mark's iPad asked, in your opinion, how will the collaborative model work with so many psychological clinicians leaving the insurance practices model for the ability to earn more income with less work, leaving out a large part of our communities unable to afford care?
Yeah, no, and I think I spoke a lot
And
where
bringing more stress.
Yes, I spoke a lot where my expertise lies largely in the neuroscience. But when I look at this from 36,000 feet, the biggest impact we're going to have on society is figuring out this issue of how to deliver affordable care. I've had conversations with my close colleagues that are primary care docs, and one of the things they always say is, well, I don't have time to talk. These people need somebody to talk to. They have, we need you to come and see them. And then I remind them that we're specialists. We have their MD, and then we're specialists on top of that. We're actually more expensive to see. So how are you going to afford that? It's just a real issue of how can you deliver mental health in an affordable way. It takes a long time. And we are getting better at figuring that out. You don't need, or the argument would be, is you wouldn't need a psychiatrist or a PhD level psychologist to see every patient all the time. And especially if you can identify people earlier on, you can develop stress reducing treatments to the people early before they reach those later stages. So you probably, any of you who've gone to a primary care doc in the last 3 or 4 years have probably noticed they ask you these questions, or at least they're supposed to ask you these questions. It's called the PHQ-9 or the PHQ-2. Have you been depressed? Have you been down? Have you been eating okay? Have you been sleeping okay? And it really, most insurances and Medicare, Medicaid actually mandate that primary care docs do that, or they won't get paid anymore. So there are ways of making sure that they're at least screening for these things early on. But then the goal really is to have what we call step-based care, where you start to develop care to people at the level they need it. So for most people that's struggling a little bit with what some people may call minor depression or just stressful events or having some anxiety, you probably don't need to see a psychiatrist, or you probably don't need to see a PhD level psychologist. Mm-hmm. You probably could benefit from maybe even a peer counselor or a mental health worker of some other licensure that is much less expensive. And then only if you're not responding to that, you would bump up to the level of an APRN, and then maybe to a psychologist, and then maybe to a psychiatrist. And it's that way of trying to provide the right level of care where it's needed, and that makes it much more affordable. But the system isn't built for that right now. Places like CVS are now trying to put some mental health workers right in their minute clinics even. So I don't know if people have seen that. So people are trying to develop ways of doing this more efficiently, but it's going to take some time.
Yeah, I'm sorry. We didn't want to hold you responsible for the failures of the whole healthcare system.
No, but it is good to call it out and to have, that. And that is specifically why I put it at the end of this talk, because I'm very excited about the neuroscience and these new treatments and new everything. But if we can't deliver it to the patients, what good is it?
Mm-hmm. We had another question from Susan Pinella, and she asked, what is known on transcranial stimulation along with meds and supportive care?
Susan, thank you for asking. So the transcranial magnetic stimulation is called TMS. Many people may have heard it as by that acronym. It's a treatment that's developed by actually delivering magnetic pulses over part of the brain. And I know when you hear that, especially if you're out of the field, could sound a little, a little bit way out of the box. Like, is this a little charlatan-like behavior? But this is very different than just waving a magnet over your head in some way. This is very high intensity magnetic stimulation rapidly developed. It was actually developed as a tool in neurosurgery. So you can stimulate over part of the cortex in a way with this magnetic pulse that will activate your brain in that region. So if I put it over what's called your motor cortex over here on your left, I can make your thumb move, I can make your leg move, I can make your arm move. It's just kind of a way of activating that the brain tissue there. It's been developed in ways that can stimulate over different parts of the brain, that we can activate those brain regions. And the idea has been very similar to what we talked about, is inducing this neuroplasticity, kind of getting the neurons to sort of become more adaptive in the way they communicate with each other. The treatment looks like it has been effective. It does have an FDA approval for the device, and actually several devices now, and even most recently for OCD, for depression, OCD. It looks very promising, and for many people, it's very helpful. Again, it's one of these very expensive treatments. The standard is usually it's usually 5 weeks of treatment. So it's 5 weeks, five days a week. So that's 25 days of coming in, getting treated. You can imagine the cost of that is not insignificant, and the ability for most people to have 5 days that they can come in, get treated, it really limits care. Some of my colleagues at Stanford are working on ways that have recently had some papers of shortening that to much shorter periods of time, using higher intensity, shorter duration of treatments. So again, it's improving, and I think it's getting there. It is a very effective alternative, especially when some of the standard treatments have not worked. But again, it's still being developed to be optimized for care.
Ted, you have a question. If you'd like to unmute yourself, you can ask Professor Sanacora.
Thank you very much, Professor. My question is this. So many people these days are so suspicious of pharmaceutical companies exploiting people. And when ketamine first came out, I mean, this is a known drug that's been used for years.
Yeah.
And suddenly it's so expensive. And I was wondering, this S-ketamine, ketamine, is there that much of an improvement, or is this just a way to make more money on an old drug and make it new?
So you hit a really important point. I think there is this very very suspicious attitude towards the pharmaceutical industry. And again, it's an industry, it's there to make money. So that's reality. The flip side of that is it's an incredibly expensive, high risk endeavor to get into this. So yes, ketamine was developed in the 1960s. It was used a lot in field hospitals. In the Vietnam War, it was a great anesthetic because you could basically do surgery in a field hospital, because unlike a lot of other anesthetics where you really need to monitor, you can drop heart rate and blood pressure very quickly and somebody can die, and respirations die very quickly under anesthesia. Ketamine was actually very safe. You could anesthetize somebody and perform surgery without monitoring nearly as closely. And it's still considered one of the World Health Organization considered it one of the most important medications in the world, because third world countries still use it as their one of their main anesthetic if they don't have all the safety precautions that we have in more developed countries. And I personally was caught right in the midst of this. As we developed the drug, ketamine, we had more evidence that it was effective, but the studies up until the FDA approved ones typically had 20, 30 people in them. Maybe the big ones had 60 people in these studies. And you were only following the people for 2 or 3 weeks. And we didn't have that real good data. Ketamine, as we know, is, first of all, it has major effects on your blood pressure, your heart rate, everything. Even though it's safe relative to other anesthetics, it's still a drug that, if used improperly, could kill somebody. Especially if it's mixing with another drug. So it does have some risk associated with it. The other thing is it's a drug of abuse. We know in many countries of the world, people abuse ketamine to get this strange, cognitive state that they get from it. So there are real risks associated with it. And it came to a point where people were using this drug without knowing exactly how safe it was and how effective it really was. Johnson & Johnson, or specifically Janssen, took the risk of doing these large studies, the type that the FDA requires to grant an indication or approval. And I said, I don't know what the dollar value was, but being close enough with it, I'm guessing it's about $1 billion. It's about $1 billion investment that they made. So it would be great. And people say, well, why didn't the NIH do that? Or why didn't somebody else do that? That's a lot of money. That would be such a chunk of the NIH budget to do something like that. Janssen did do it. S-ketamine, as I said, is really, regular ketamine has S-ketamine in it, but it also has R-ketamine. And all they did was take the R-ketamine out. The reality of why S-ketamine was chosen is it has a higher affinity for the receptor. So it's more potent than the R. So you could give less of it in volume. So if you're going to use a nasal insufflation instead of IV, it was easier to deliver. That's really the main thing. So it is a little bit easier to deliver intranasally. Whether or not it's even as good as racemic ketamine, we don't know that for sure, because those studies have never been done head to head. And again, it would cost another few $1 million. We've actually recently applied to do this to an agency, but it's going to cost upwards of $10 million to test if it's as not inferior to the other version. They're just very expensive. But I think the main thing to come out of the whole thing is the FDA approved this treatment with what's called a REMS, a risk evaluation and mitigation strategy, which means you can use this treatment, but you have to do it under certain conditions because there are risks associated with it. And I think that's something, no matter how you're giving the drug, people should consider, is how to do this safely. I just worry about use of the drug, what's called off-label, in ways that really isn't safe. And the last thing we want to do is make anybody worse than they were to start with by giving these drugs. It's a very long-winded answer. I'm not trying to defend the pharmaceutical industry. I'm not trying to say they're evil or guilty. It's a really difficult thing. It's so expensive to do these studies. We can't do it without the pharmaceutical industry. So I think the best is to try to manage it and to be as transparent as possible.
Thank you.
I hope that was helpful.
So when you look 5 years or 10 years down the road, will somebody actually have done the safety studies for the mixed enantiomer ketamine?
Well,
And will we know? Will we know the answer?
We will hear in the next 2 weeks or 3 weeks if our proposal was accepted. So my colleagues and I at Yale have submitted to a very interesting group. If people have never heard of it, it's called PCORI, the Patient-Centered Outcome Research Institute, which is a very interesting development. It's kind of the research arm of the Affordable Care Act. So you probably all have heard, the Obamacare, the Affordable Care Act, in a roundabout way, kind of forced the insurance industry. They bent their arms to give money to research. And this is one of those. And it's interesting that the main mission of this research institute is to look at the efficacy and effectiveness of these treatments from the patient's perspective. That's why it's called Patient-Centered Outcome Research Institute. So we've just sent in a large application. And again, to do this costs millions of dollars. You can't do this even at one site. We have many different hospitals and other sites involved because unfortunately, biomedical research is expensive. And the one thing I've learned is if you run a study with 20 people, you might as well not run a study because the variability is just too great. For anybody who knows statistics, you can't get a reliable answer with that.
So Judith asked the question, what about the use of electroshock therapy?
Yeah, so ECT, we call it electroconvulsive therapy now, is the medical term that's used. It is one of our oldest treatments. It's been out for 70 years. And it still is what we consider the gold standard in the field in terms of effectiveness and efficacy, meaning for people that have not responded to these oral medicines, moving on to receiving the treatment with ECTs still seems to be the most effective. We're in the middle of a very, very large study, well, very, very, meaning 400 people. It's us here, it's us at Yale, it's the Cleveland Clinic, obviously in Cleveland, Mount Sinai School of Medicine in New York, Baylor College of Medicine in Texas, and Johns Hopkins in Maryland. Our 5 sites are doing a study specifically testing ketamine versus ECT, randomizing people to receive one or the other treatment. And we'll have the results of that study within the next 6 months, which is really exciting. But to this point, I would say that ECT is still considered the gold standard in our field. The problem is it's, again, very expensive for one, but 2, it does have some real side effects. 1, you have to receive general anesthesia many times. 2 is you're basically, the way the treatment works is by generating a seizure, which we think also then stimulates the neuroplasticity and allows the brain cells to sort of set up a more adaptive way of communicating with each other. But it does have some problems with memory loss and others, especially in some people. And we're not always great at predicting who is going to get the benefit and not get the side effects. I always tell people, if it was me or my family member, I would never hesitate to get the treatment. It is highly effective. And if somebody is being devastated by depression, which it does do, or there's a real risk of suicide or other major negative impacts on life, ECT is still our gold standard treatment. And I think it's grossly underutilized, at this time.
You mentioned that the psilocybin studies would be very, very expensive. From what I've read, the size of the effect seems to be quite large. Wouldn't that drive down the number of patients and thus reduce the cost of the clinical study?
So that's what, and we are also, I keep saying, we do a lot of studies. So we're doing a large psilocybin study at Yale. We're very interested in it. We're part of a study that's sponsored by the USONA Institute, doing a study for psilocybin for depression. That is the hope. I mean, it looks, this initial data that has come out of Johns Hopkins, initial data coming out of the UK, suggests that you may be able to give 1 or 2 doses of this treatment and have benefits that last for months or potentially years. The goal would be is that this would be almost curative. Remember, I said in the beginning that part of the treatment is treating the symptoms. The other part is actually changing the course of the illness. And the hope is that this may change the course of the illness. The early data look very promising and we are very interested in it, but I've been around long enough to see a lot of things that look really promising early on. And Dan, I know you've been in the industry for a while, you've seen that a lot of things look so good to begin with. And then as you move through time, the efficacy tends to decrease. And I'm hoping that this really is the breakthrough that we're all wishing for. But until those big studies are done, we're not going to know that answer. And the way it is, it takes hours and hours of treatment. One-on-one, in fact, 2-on-1, two clinicians to one patient over many, many hours, which would make it prohibitively expensive to pretty much anybody.
Mm-hmm. So one last question. If you look up seasonal affective disorder, you find that sunlight is the first thing that you're to try. Should people go outside more? And if they're feeling anxious or depressed, is that something that you
I think
would
that
recommend?
is a great segue right now while the sun is still shining. Yes. No, I mean, in reality, so much, and I hope one of the main messages that this talk brings up is so much of what we can do is preventative or trying to even mitigate or attenuate some of these effects of stress and other negative toxic effects we may have. exercise is probably one of the most important things we have for that. And most people that have ever come to see me, come expecting that I'm going to be trying some experimental medication or something like that. And the most common thing I'm going to recommend, first of all, is, join a gym if you can, or exercise, things like mindfulness, really sort of these simple low bar things, because all of medicine it's all about risk and benefit. And, these are things that can be done at very minimal risk and really have a big benefit. Some of these other treatments, as we get more and more aggressive, talking about ketamine and ECT, they can have really big benefits, but they also carry real risk with them. So you always want to balance those two, and things like exercise, getting sunshine, mindfulness, just taking a break from your daily, life, is something we all should be doing. There's almost no risk associated with it and potential for great benefit. So with that, I would recommend everybody get out before you start to watch the football games.
We do have one late breaking question from Walter, and seeing this seems sort of a good way to wrap up, since you started talking about how to think about the disease. He said, how do you separate cognitive aspects of the disease from chemical ones? And I know it's a difficult question, but if you can just point us in the right direction.
It is. So now we can go back to philosophy and go back to Descartes, whether you're a dualist or not. For me, they're one and the same. And I think this is where the field has changed. If you look through the history of psychiatry, and it's a relatively recent history, even going back just prior to my entry into the field was dominated by what was called the psychodynamic theory. It was therapists, psychoanalysis was the predominant thing. Even at Yale, many of the older professors were psychoanalysts who would talk about what was the social interaction, what was, it sounds like the question of the cognitive side, that was what the critical thing was. And then came this revolution to biological psychiatry. It's chemical, this is what it is. I think now we're at the point in the field that those two differences are kind of melding together. I don't see them as two different things. We know that your thoughts have dramatic effects on your brain function, and we know your brain function has dramatic effects on your thoughts. So they're one and the same in my mind. And we know, as we said, stress, these ideas of having stress actually has physical changes in the brain. And when your brain isn't functioning right, it puts you in situations that makes more and more stress. So I don't know how to separate the two. And I look at it as a model that you have to address both of them simultaneously. I hope that was answering the question.
I think so. Joanna has a question. Would you unmute yourself, Joanna?
Okay, thanks. First of all, I want to say that I appreciate that you giving the possible conflicts with the therapeutic pharmaceutical companies, and that you want it to be made available to many, but and that you really did outline about the cost. But is the paying back the $1 billion possibly partly because it has to be administered in a clinical setting with doctors and nurses and offices? If the thing itself is not an expensive drug, why is it so expensive? And then, I, as you are probably disappointed too, I think people who are living now, who can't wait till it gets reasonable, if it ever will miss out until it's reasonably priced. I mean, these people in the, in the VA hospital, it was obviously subsidized and they were able to take it. But another question that it can be left just as a, as a question, but, after the year, since it hasn't been out that many years, after all this intensity, after that year, do people, go back and if they stop taking it after that year, is there regression and they have to start up again. So, I mean, this is
Yeah.
tough,
So
and I know it's tough for you too.
no, you hit, John, a very important points, and the two ones, if I heard it correct, the cost is one thing. I want to come back to the long-term benefit too, because that's a separate. So please don't let me forget that. Fortunately here, I mean, through Yale New Haven Hospital, we accept most major insurances. We accept Medicare covers it for us. I mean, here it works pretty well, but that's still a relatively small percent of the big population. We're very fortunate to be in an area where we can do it. We treat most people without a problem. As long as most insurances, and as I said, even Medicare covers it. So that makes it accessible to many, but that's here in New Haven, in Connecticut, where we have a really special healthcare system in a way. But it still means there are many people that can't receive it. The other part is really important, is what is the long-term benefit for this treatment? And is it a smart thing? It is so expensive. And even if you're getting people better for 2 months, 3 months, is it really worth the cost if you can't keep people better? And that work is still being done. I think for the most part, if you're able to continue to get treated, the care seems, the outcomes are very positive. We do have other grants. One of my colleagues, Sam Wilkinson, has a large grant looking at combining this treatment with cognitive behavioral therapy, and now even trying to move to computerized, because the next part of the problem is, oh great, cognitive behavioral therapy, good luck finding a therapist that you can find. I mean, they're even more in demand than psychiatrists at this point. But the idea of trying to move to some computer-based ways of doing this. So I think you're spot on, the fact that we need to not only develop these treatments to help people, but how to keep them better in a way that's affordable. And that's really, I think, what we need to be doing as a field.
Thank you.
All right.
Okay, well, thank you so much. And I know I learned a lot, and I think everybody did. We really appreciate your joining us today. Someone did ask the question whether this would be available, and the answer is yes. Most of you, I think, are on the Branford Forum mailing list. If you're not, send me an email, and I'll put you on there. So in a couple of days after we've uploaded it to YouTube, we'll send the link around and everybody will be able to review it, look at the slides, et cetera, et cetera. So thank you everyone for coming. And Professor Sanacora, thank you so much. I hope your football game hasn't started yet, and we'll
Thank you. It was really my pleasure.
We really appreciate it.
Thanks a lot.
Okay, bye everyone.